محمد فارس. صباح الخيرات يا جماعه. صباح الخير يا حضرتك. صباح الخير.
هول دي حمزه البرفكشن. Bismillah ar-Rahman ar-Rahim. We start the second session today, and it's about elbow injuries. I am pleased to have with me as chairman my dear friend and brother Professor Yasser Safuri and my dear friend and brother Professor Muhammad Mustafa Out, and they are both well-known hand surgeons, Cairo University and Asyut University. I myself, I am Abdel Salam Eid, Lagazig University. And we will start this session. I will hand the microphone to Dr. Yasser.
Thank you very much, Dr. Abdel Salam. We are very honored to have this very eminent board to discuss a very important topic in elbow, which is the fracture dislocations. And we have selected these types we have selected the titles so that we can have a full idea about the fracture dislocation of the elbow. Our first presentation will be Dr. Abdel Salam Eid, Professor of Orthopedics at Zakazaki University. He is also a very solid and strong member of the EXA, Egyptian Society for Surgery of the Shoulder, and he is specialized in the upper limb surgery. Dr. Abdel Salam.
الفلاشة
احنا unfortunately يعني في technical problem, so we'll start with Professor Yasser Safuri. He will talk about fracture dislocations of the elbow other than terrible triad. Supposedly I have already spoken about the terrible triad, so now we will get it the other way around. So Dr. Yasser will talk about fracture dislocation of the elbow other than the terrible triad.
Okay, so most of us in the training program during residency, all of us know the terrible triad. Okay, what is the story of the terrible triad? It begins with a fracture dislocation of the elbow, then the surgeon reduces the elbow. After some time, it redislocates. And we don't know the exact cause because sometimes the X-ray shows a very small chip of radial head fracture, a small chip of coronoid fracture. So it looks as if it is an innocent fracture, and we reduce and put in a splint. After 3 weeks, we remove as if it is a dislocated elbow. But later on, it gives terrible results. Unstable elbow, maybe osteoarthritis later on. So most of us during our residency understood from our professors what is terrible triad by the experience, and all of us know it. Just look to the X-ray, head radius, coronoid, lateral ligament. This is a terrible triad. Go and fix the radial head or replace, reconstruct the ligament, plus minus the coronoid process. We all know this, okay? But what about other fractures? Sometimes there are fractures, dislocations of the elbow, which look as if they are innocent fractures and straightforward fractures, but later on they give us terrible results. So I'm trying in this presentation to let these fractures highlight some important points in your brain to understand these fractures, so there are no more later terrible fractures, but they are controlled with proper diagnosis and management. Okay, so what are these three fractures? To me, these are the three important fractures which sometimes are mislooked or misdiagnosed, and they end by a catastrophe. The first one is the transolecranean fractures. It is a fracture through the olecranon. So we have lost the ulnar-humeral relation between the ulna and the humerus. At the same time, all the mass, including the ulna and the head radius, are just displaced anteriorly. It cannot be managed as a fracture olecranon. And it cannot only be managed by a plate, but you should also, if indicated, reconstruct the ligament. The other fracture is the Montegia. All of us know the simple Montegia, according to the Baddock classification, but sometimes this type of Montegia is comminuted and has a fragment related to the coronoid. If you just treat it as a Montegia without addressing this coronoid fracture or the ligament, it will end by a dislocated elbow. The third one is the selected fracture coronoid, but this is in a sagittal plane. If you look at the X-ray, it appears as if it is an undisplaced fracture and it can go without surgery. No. All the elbow will be subluxated laterally, and these fractures end up by quick osteoarthritis. You should diagnose and treat properly. This is the aim of my presentation. Okay. What characterizes these fractures is that all of them have ligament hinges. So it's not only a bony element, but also it is a ligament element. And it is an unstable elbow. So whenever you have these types of fractures, you think of these four bony fragments, bony and ligament fractures. You look at the coronoid, you look at the ulna, you look at the radius, and you look at the ligaments. Curl, okay? What do I mean by this? I mean that there's a lot of confusion in treating these fractures, and there's no plan of work to do our surgery or our prognosis. Because most of us look at these fractures as selected classification. So when you have a fracture, you look at the coronoid and say, which type of Regan and Borghi classification? Then you look at the ulna, oh, this is a Montegia. What type of stage of the Baddock? Or you look at the head radius and say, according to Mason classification, it is type 2. Then you proceed in your surgery according to these specific fractures. This is not the way to treat such fractures. If you go to the basic science, there's the columns theory. The column theory is related to the humerus and the radius and the ulna. It's one column, but we are going to speak about the ulna and the radius. The column says that there's a medial column, lateral column, and an intermediate column. It's a bony structure also to the ligaments. So if you look at the slide, the above one, the olecranon is formed from two parts, the anterior facet, posterior facet, and in between there's a non-articular area. Okay? So when you reduce the ulna to the radius, to the humerus, you should reduce in the proper alignment so that you have returned to the congruity of the olecraneal fossa. But at the same time, there is a facet, anterior facet, which is divided into two parts, anteromedial and anterolateral facets. This is how you think of the olecranon. So it's two big articular, in between a non-articular area, then this facet anterior is divided into two parts. If you look at the bony insertions in the ulna, you should also always look at the X-ray at the sublime tubercle or the supinator crest, because this is the attachments of the ligaments. Another important point in the basic science that all the ligaments of the elbow are going from the humerus to the ulna, mainly. And then they enclose the head radius by the annular ligament. But there's always the humerus, the ligaments go to the ulna, fix the ulna. So if you have on the lateral aspect, the most important is the anterolateral collateral ligament, and on the medial side there's the anteromedial ligament. These are the main structures which are very important for stability. So we go back to the theory, column theory. This column theory respects the humerus and the ulna and the radius, not only the radius and the ulna. and it's related to the ligaments. But this slide tells us that the intermediate column, it could be important, or it is usually reduced if you reduce the lateral column. So if you reduce the lateral column, then maybe you go out without any complications. If we go back to the first slide, these are the 3 fractures. How can we treat these fractures? Is there a certain classification? There's no classification in the literature which specifically describes these fractures. But there are 2 useful classifications, to me at least. This is the Jupiter classification, who describe in types of Montague fracture dislocations. There are severe comminution, and the radial head is subluxated, dislocated posteriorly. It's only description of the fracture other than a complete framework of management. The other classification, the Wrightington classification, which began to realize that the facet, anterolateral facet, there's anteromedial, anterolateral, and the different directions of fractures. This is more important than the classic classification tip base of the coronoid. So the first type, which is very dangerous, as described by the AO, is the transolecranon, where you have the fracture through the olecranon. So there's no proper relation between the humerus and the ulna, or the olecranon fossa. You should reduce it properly. At the same time, you have all this block of bone of the head radius and the ulna dislocated anteriorly. This is the classic transolecranon fracture. You cannot treat as olecranon fracture and tension band. You will end up by failure. So this is how you should treat them. Put a plate and posterior plate. Then you try to fix the bony fragments related to the coronoid. As I said, according to the fracture and the CT scan, you should reduce the coronoid, and remember that there are certain bony fragments, as I said, like the sublimb tubercle, should be reduced and fixed. This is another type of transolecranon. Why transolecranon? Because as you see, the relation between the olecranon fossa and the humerus is disturbed. You cannot just pull the ulna and have a distraction between the anterior and posterior facets. It will end by arthritis. You should reconstruct the olecranon, and then you build up the ulnar length, and never forget that the coronal process in this case is comminuted and it's a big fragment. Plus, you may have, as you all know, we should have known from the cerebral triad, that sometimes the head radius and the ligament can also be injured. How can you treat these patients? You should treat them by fixing and ligament reconstruction of the medial lateral structure accordingly. So if you look at this case, the ulna and its relation to the humerus is disturbed, so this is a transolecranon. Then you have comminuted an injury of the coronal process, anteromedial facet, and also you have like a ligament injury, and also have a head radius. So it's everything. You think of it like I said before, curl, coronoid, ulna, radius, and ligaments. There's no specific classification which makes you plan this type of surgery. So here we did everything. Put a posterior plate, anatomical plate, reduce the olecranon, reduce the coronal process, even if we have to put other screws than the screws through the plate. And also we check the stability of the elbow. Sometimes we have lateral instability, and you should repair the lateral ligament. Otherwise, this will be an unstable elbow. How to do this? We do a posterior approach. I like to have the patient in supine. Some people have it in lateral position. For me, it's supine position because all of us know the Kaplan approach, over the top, ligament, we all do in supination. So it's the same idea here. So midline posterior approach, then you do long skin flaps, and you do 2 windows, medial and lateral windows. From the lateral window, we create the Kaplan approach, which is very suitable for reconstruction of the ligament and the head radius. And from the medial aspect, we do the over the top, in which we split the common flexors, and you can see the ligament and deal with the anterolateral, anteromedial facet if fractured. But it's very important after you finish your fixation to test the stability, because most of the cases we are unable to do an MRI in fractures. Very rarely do an MRI in fractures. But after you finish, you should see the stability, the valgus and the varus stability. We all know how to test the valgus test, and also the varus, okay? Both tests you do clinically And if you find there is instability, then you go ahead with repairing of the ligament. The other type of fracture is the Montague, but it's not the simple Montague as you see here, in which there is a fracture of the ulna, dislocated head radius, in which you should put a posterior plate and reduce the head open if it's not reduced. But we are talking about complicated cases. Complicated cases, as I said before, these types of complicated cases were described by Jupiter, in which there is comminution, and accordingly he said that it can be fixed by a certain type of plates, and you should reduce the large fragment of the coronoid. So if you see a fracture like this, you should do a 3D CT scan to see the orientation of your and planning of your fixation, and always put in mind this type of fracture of the anterior part, which is the coronoid. Okay? Here the surgeon he placed an anatomical plate or tried to reconstruct a plate, and he placed it posteriorly, but he forgot to reduce the coronoid fragment, as you see here. So all the elbow was subluxated. You should have reduced this type of anterior part of the coronoid. Although it's a big fragment, it could have been reduced if you had used anatomical plates, because they have the screws which are introduced into the coronoid. Or if he is logical, he should have fixed the coronoid separately by a plate. This surgeon also did all the job. He placed a posterior plate and he had a head replacement, but he forgot the main principle of these types of fracture. They should reconstruct and the part of the coronoid. Otherwise, you'll end up with a catastrophe. So this is also terrible. These are terrible fractures. Sometimes you have like complicated cases. You should have logical thinking. Always will go back to the basics, which is the ulna, and you see which type of fracture and which type of facet. You see the head radius, you see the ligaments, and you deal accordingly. So here, although he did not use an anatomical plate, but he was logical thinking. He placed the plate posteriorly, he did fixation of the coronoid, he did fixation of head radius, and he examined the elbow for the stability and the ligament injuries. This is another case. He was not able to fix. You should be prepared by replacing of the head radius. But he did the job properly, and as you see the plate, through the plate he introduced the screw which fixes the coronoid. He was lucky enough that this was enough. But at the end, you should reduce this type of fraction, and even if you put an accessory plate. Is it enough to put the screws through the plate? Sometimes yes, sometimes no. So you always should prepare the mini plates of the hand surgery, because just in case if you want to buttress or fix the coronoid process. This is the third type, which is, it looks as if it is an instant fracture, and it was described by the AO, and they have like a buttress plate for these posteromedial rotatory instability. We sometimes call it reverse cerebral triad. So the energy here from the posterior and medial, then it rotates. It may have a fracture of the anteromedial facet, continue until it ends with dislocation and injury of the lateral ligament. It's the same as the cerebral triad, but in the opposite direction. It's not an instant fracture. So if you look at the X-ray here, you should reduce, fix, and examine also the stability. So it's not a good way to think of this fracture as tip fracture, base fracture, but a little bit of orientation by the Wrightington classification. But at the end, you know that these facet or anterolateral facet, there's anteromedial and anterolateral, and both of them should be reduced. And as I said, the anterolateral, sometimes we skip fixation if the lateral column and the head radius was completely reduced. So if you take a 3D CT scan, which is very important, these complex fractures, it's a sagittal fracture. After some time, all the elbow subluxate laterally. You should fix these types of fractures and then examine if there is a ligament injury, you repair the ligament. Okay, this is an unclassified fracture, but you know the basics. If you look at this fracture, you go back to the curl. Is there injury of the coracoid? What type of fracture of the coracoid? What are the bony insertions of the ligaments? The radius, is it fractured? What type of fracture? Should be prepared by fixation or replacement. The ulna, the degree of comminution, and the ligaments. All of it. You don't have to go back to the specific classifications. Now you have a full plan. And also you think here that this is not a transolecranon, and it's not a Montega. It's not a transolecranon because there is comminution of the ulna. And it's not a Montega because there is loss of the ulno-humeral congruity. Okay? So there's no specific classification of these fractures. You should have logical thinking. This is how you treat this full bone fixation, even the small fragments and ligamentary pair. So to summarize, always think of this pattern of fractures not as bony fragments, or these fractures are like bony fragments and ligament fractures, and you don't have a solid classification which gives you an idea of how to plan. Perennial approach that you have a medial and lateral approach, because sometimes you need to repair the medial ligament, although it's from the lateral side fracture dislocation. Always prepare to have radial head replacement in addition to the fixation. Prepare many plates to augment your fixation in some cases. Test for the elbow stability and ligament stability. At the end, after doing your fixation, if you are solid enough, you should begin early rehabilitation, because this adds to the dynamic stability. It's with you, not against you. Thank you very much. The EXA will be hosting, the EXA is the Egyptian Shoulder Society and Elbow Society, will be hosting here in Egypt in 2029 the International Congress of Shoulder and Elbow. All of you are invited. This Congress is the Congress of the whole world, and at least 4,000 attendees are coming. Thank you very much.
Thank you, Professor Yasser, for elegant presentation and tackling a difficult subject. So the message is to think about the anatomy. What is fracture regardless of classification, regarding bone, ligament, and so on, so to fix whatever injury.
Sometimes people think of the fractures, dislocation of the elbow, as if they are only bony elements. No, there are bony elements, ligament injuries, and also it's the small fragments which are important more than the big fragments. So you should do a 3D CT scan and look at the bony fragments which are related to the ligaments. If there is a problem, you should fix these small fragments by mini screws or a separate plate.
Regarding articular cartilage, if we have a flip of cartilage or lost fragment, so what do you prefer? Is to remove it or to fix it? What is the size?
If it is in the ulna, in the olecranon fossa, you should remember that there's a non-articular part in between the two fossa, the anterior and posterior facet, there's a non-articular part. So you can remove this comminution, but you should respect the curve of the ulna so that the posterior facet, which is most probably no injury of the cartilage, should be congruent with the anterior facet. That's the maximum you can do. For the other side of the head radius, if it is a very small fragment, you can just excise, no problem.
Thank you. Any questions for Professor Yasser? Yes, please.
As I said, there are dynamic stabilizers of the elbow, not only static. One of them is the brachialis muscle and the pull of the brachialis muscle. That's what sometimes you put an X-ray, post-operatively, you find that as if the elbow is subluxated. Once you begin flexion and extension, you don't have to do more than flexion and extension, then you have like a dynamic stability. This is the first point. Second point, that the elbow sometimes most probably has like a flexion contraction if you do not do an early rehabilitation. So from the first day or after the second day, you insist that the patient leaves the elbow with gravity to reach full extension. Always worry about the full extension. Flexion will come with gradually. But if you miss these 2 weeks, first 2 weeks, and has like 10, 15 degrees of flexion, it's very difficult to return back to good function and extension after the first 2 weeks. So my advice is that you begin early rehabilitation and that you insist that in the first 2 weeks, you have full extension of the elbow.
Any other questions? Yes, Professor.
This is a very nice question, a very good question. It يعني shows that you have good experience in elbow fracture dislocations. That's why I always advise that you should have an external fixator. Okay, an hinged external fixator in these cases. Sometimes it is rare, but after doing all your job, you find that the elbow is still unstable. This condition, you do not put bypass a K-wire, but you put an hinged external fixator from the humerus to the ulna, and you begin early rehabilitation according to the angle of subluxation. So if you do all your job, then at the last 30 degrees, it has like subluxation, although you did the ligaments, then you put an external fixator hinged from 30 degrees to full range of flexion. We do not like to pass a K-wire through the cartilage.
Thank you, Professor Yasser, for tackling this very hard topic. And now we are moving to the next speaker, Professor Absalam Eid, the former Dean of the Gazig University Faculty of Medicine. He will give a talk about the management of terrible triad. Professor Absalam.
Thank you, Mr. Chairman. The term terrible is rarely seen in medical terminology. There is very few places in medicine where you see a disease described as terrible. So, in which case, when we look at the X-ray showing a terrible triad, should we do like the painting and say, Ya Lahwi, it's a terrible injury? So, it is an intimidating term to the treating doctor as well as, of course, to the patient. But maybe by the end of this presentation, we will find that it's no longer that much terrible. The anatomy of the elbow as regards stability. There are static constraints and dynamic constraints. Static constraints are primary and secondary. Primary static constraints, bony configuration of the elbow, the intimate relationship of the ulna with the distal humerus, with the coronoid engaging the coronoid fossa in flexion, the olecranon engaging the olecranon fossa in extension. This provides definite static stability. Also the ligaments. On the medial side, the medial collateral ligament, especially the anterior bundle, and on the lateral side, the lateral collateral ligament with its 4 components. And the secondary static constraints include the joint capsule, anteriorly and posteriorly, the radiocapitellar articulation, and the common flexor and extensor origins. Dynamic constraints include the muscle units that cross the elbow joint, such as the anconeus, the triceps, and the brachialis. They provide compression forces across the joint as well as proprioception. So, what are the mechanisms of elbow instability? The primary mechanism is posterolateral instability, and the sequence of injury progression is debated, but there are also medial dislocations. The range of elbow instability ranges from simple dislocations, complex dislocations, and fracture dislocations, such as Professor Yasser Safuri outlined a few minutes ago, the terrible triad, and the untreated chronic dislocations. As regards the terrible triad, it's a complex dislocation of the elbow, and it was named so by Hotchkiss in 1966. It happens due to a fall on the extended elbow with valgus and posterolateral rotatory stress. It's usually a high energy injury. And the triad that we are speaking about is composed of a posterior dislocation, a radial head fracture, and a coronoid fracture. Of course, they are often associated with collateral ligament injuries. The sequence of injury usually starts on the lateral side, the lateral collateral ligament, and proceeds medialward. And this may end by injury to the medial collateral ligament, and we can see that this is the progression of the injury. So how do we diagnose? Diagnosis is by clinical examination and radiological investigations. Clinically, from the history, pain, swelling, deformity, inability to move. We don't forget neurological examination, and we also should examine the joint above and joint below clinically and radiologically. Radiologically, the X-ray is usually evident, and of course, because it's an articular injury, CT is usually required. Non-operative treatment may be appropriate in selected lower demand patients, in elderly patients, provided that a congruent reduction can be achieved. So how do we approach the surgical management of the terrible triad? When we outline the injuries, we have a radial head injury, we have a coronoid injury, and we have the dislocation. So we have to look at the radial head at first. Is it reconstructible or non-reconstructible? If the radial head is reconstructible, then we would make a lateral incision and reconstruct the radial head by open reduction internal fixation. And the lateral collateral ligament will be repaired from the same incision. The coronoid can be repaired through a separate medial incision. After that, we test for stability. If it's still unstable, we would repair the MCL. After that, again, test for stability. If still unstable, then you may put a hinged external fixator. If the radial head is non-reconstructible, then we remove the radial head and take a chance to repair the coronoid from the lateral incision, because now the radial head is not in the way. Then we do radial head replacement, then lateral collateral ligament reconstruction, and then assess. If needed, we may repair the MCL. If still unstable, we put an external fixator. So about the radial head, it follows the Mason classification. If it's type 1 or 2 and can be, type 2 needs to be reconstructed. Type 1 usually it's a chip that needs not be reconstructed. Type 3 will need replacement. As for the coronoid, it follows the Reagan-Murray classification, with type 1 avulsion of the tip, type 2 less than 50%, and type 3 more than 50%. There is a debate regarding type 1 where some authors say that type 1 coronoid fracture usually does not affect elbow stability that much, whereas some authors insist that it also be repaired. But then again, this comes to intraoperative assessment. If there is instability, then definitely repairing the coronoid will improve the stability. The lateral approach is the workhorse. However, posterior approaches are extensile with better medial exposure, but create large skin flaps. Lateral approach, we can work, if we replace the radial head, we can work through the space to reach and manage the coronoid. And we may need to add a medial approach if the MCL requires reconstruction. The Boyd approach is a posterolateral approach. It allows access to the radial head as well as the upper ulna. And it may, I find it myself useful in managing such cases, may obviate the need for a medial incision. So we fix the coronoid and repair or replace the radial head and assess the stability and repair or reconstruct the LCL, then assess stability and then MCL as needed. In challenging cases, both the collateral ligaments may need reconstruction. So this is a 30-year-old manual worker with terrible triad injury. And I would like to take the opinion of the audience about the radial head fracture. Do you think this can be internally fixed, or it would need a replacement? From the available X-ray, would you think this radial head can be internally fixed? Those who think it can be fixed can raise their hand. Those who think it needs replacement, very few people think it needs replacement. Because, you know, here in Egypt we have logistical difficulties, and if we are going to replace the radial head, we have to be prepared in advance with radial head prosthesis, etc. So, if we look here, this is a fragment of the radial head, and this is another fragment. Are we in agreement? What about, is this, these two fragments are in contact with the radial neck? They are not. So how do we fix? Those who were in favor of fixation, there were a lot of people in favor of fixation. So how do we fix?
Some doctors reconstruct the head on the table. They fix it with screws and then take this head back and fix it to the shaft.
So we take the head out and reconstruct it with screws,
Some doctors
screws,
do.
and put a plate maybe.
Anyone has the same experience? Yeah.
Fine.
If it is not so comminuted, 2 or 3 fragments, so you can reconstruct on the table by screws and then you get it back.
But
and
if
put it
the
there.
radial head is completely detached from the radial neck, how successful would we suppose that we can get with putting it back together and putting it on the neck and fixing all of this? Humeral head. Femoral head. Oh. And it may not unite, and you may have to go back again and do another operation. But we need to do the operation with the best chances of success. Anyway, this is the CT 3D. You see here, these are the 2 parts of the radial head. Who would like to put this back in place? So anyway, this is what I did. I did the Boyd approach as I told you, and the radial head, we removed it because we found that we could not put it back in place and hope for a union. The radial head prosthesis, I inserted it press fit without cement because the patient was about 30 years old. And this is the final follow-up. The coronoid, we were able to approach the coronoid from the Boyd approach because with the radial head out of the way, you get some space and you can put this stainless steel wire from front to back and tie it over the back of the ulna. And here is the result. مفيش نت هنا. Unfortunately, Anyway, the patient was able to extend like to minus 20 degrees and flexed to 120 degrees, and pronation supination was 70 degrees. Thank you very much.
Thank you, Professor Absalam, for.
I'm sorry. Sorry. I'm sorry. Of course, terrible triad is not without complications, and there are complications for the management that may reach up to 47.4% for open reduction internal fixation versus 20% for arthroplasty. And thank you.
So you want us to make تسقيف مرتين. So any questions for Professor Absalam about the terrible triad? Yes, please.
Just asking about the nice case you do, Professor.
علي صوتك.
If there is any ligamentous injury you found in this patient?
I'm sorry, I cannot hear you.
There is ligamentous injury found in this patient?
Yes, when you approach laterally, the lateral collateral ligament is in your approach, and you keep it to the end of the operation and you repair it. So we were able to repair it directly without the need for anchors or anything. So when you reconstruct the radial head or replace it, you provide secondary stability for valgus, secondary valgus instability. You reconstruct the coronoid or repair it, and then you reconstruct the lateral collateral ligament. So now the elbow is stable, and you don't need to check on the medial or repair it, and you leave it without repair. Unless when you examine there is still instability, then you have to do it.
So when can I start physiotherapy in this patient?
I'm sorry?
Start physiotherapy in this patient.
Physiotherapy.
When can I do it?
As Dr. Yasser said before, if you are sure about your repair and your fixation, you can start physiotherapy as soon as possible. So you give him a few days to rest and for the edema to subside, and you start assisted passive, and then you progress with physiotherapy.
And this duration will not affect the ligamentous repair?
I'm sorry?
This duration, when I start early, it will affect the ligamentous repair or not?
The physiotherapy?
Early rehabilitation will.
Early rehabilitation, if you have solid repair, you are not afraid about anything. And also you have other bony reconstructive procedures that help the stability of the joint. So now you have the radial head in place and the joint is located. The edema has subsided and soft tissues are doing well. You can, as I said, start gentle, assisted, passive exercise under supervision. And you always, in such cases, you need to keep the patient under your eyes. I mean, the physiotherapy program should be supervised by you yourself, and you follow the patient regularly so that you can fine-tune the physiotherapy program to avoid any aggressive physiotherapy that may endanger your work.
In physiotherapy, just if you reconstruct or repair the lateral ligament in the proper isometric point, there is no stress on the ligament in flexion and extension. Don't worry. The other muscles, dynamic stabilizers, give more stability. So what you can do is that you put a hinged brace. So that prevents valgus and varus, but it allows flexion and extension. And it's very important that before you finish surgery, that put the upper limb in full extension and pronation of the forearm. If it's stable, no problem with the physiotherapy.
Any other questions for Professor Absalam? Yes.
Regarding the triple triad, when I replaced head radius, sometimes we have all sizes.
You have what?
All sizes of the radial head. So I have a small size or large size will overstuff. Which to
For radial head replacement. For radial head replacement, we are faced with this problem. There are limited sizes available. You should strive to put the radial head that provides stability but does not overstuff the joint. And because overstuffing will lead to arthritis, will lead to degenerative changes, and even if you do it, you may not be able to reduce the radial head in place if you put it with cement, if you put a larger head than necessary. So I would not, of course, put a smaller size. As regards diameter, maybe smaller is less harmful than overstuffing, but provided that you make it proud enough to contact the capitulum. So if it makes contact with the capitulum and it's keeping the radiocapitellar joint congruent, then maybe it's safer than a bigger implant. But of course, if you have the perfect size, this is much better.
Yes, please. This is the next lecture will be about the radial head. Okay. Thank you, Professor Absalam, for a very nice presentation.
Okay.
Other question? Yes, Dr. Saeed.
I have a personal experience. If you have the radial head completely, but maybe not in such cases, maybe it was a different type of cases, a simple radial head fracture, but it's not the type that you could fix easily. I mean, it was like this one, two main fragments, but totally separated from the neck. There is a concept that you may put it back and fix it with a plate, and it will work as a spacer. If this radial head heals to the neck, then you gained everything. If it doesn't, you may remove it later on if it doesn't heal, and you will have maintained the radial height, and you have avoided proximal migration, the one that we fear in radial head injuries in Essex breast injury. So you put it in place, put a plate, and you hope for union. If it doesn't happen, you can remove it later, but not in the terrible triad cases, which is a different thing.
Thank you very much, Professor Absalam. Now we're moving to the next speaker, Professor Abdurrahim Rafou'i. Dr. Abdurrahim Afif, yes? Rafaawi, from Morocco. So we'll hear a different experience from Morocco. And they are rich people, so we have radial head better than the one we have. You will give the lecture in French or English? Dr. Abdurrahim, in French or in English?
We will try in English, Arabic,
Okay, okay.
French.
Okay.
انجلش عربي فرنسي شوي. يا لو سمحت. أود في البداية لا أود أكبر دي شوي.
دكتور عبد الرحيم رئيس الجمعية المغربية لجراحة اليد والطرف العلوي. هم عندهم هناك جمعية جراحة اليد والطرف العلوي. هو كان رئيس السابق ومن المؤسسين ليها، وله نشاط كبير جدا في جراحة الكتف والكوع واليد، وبيعملوا مؤتمرات سنوية برضو في المغرب زي هنا، وفي تعاون بينهم وبينهم يعني قوي جدا.
أود في البداية أن أعبر عن خالص امتناني للجنة المنظمة وكذلك لرئيس جمعية العظام المصرية على دعوتهم الكريمة وعلى حسن الاستقبال والضيافة. وأود كذلك أن أشكر صديقي العزيز الدكتور باسم على دعوته وحرصه على أن أكون جزءا من هذا المؤتمر هنا في أرض الثانية مصر، وأتمنى أن تكون هذه بداية لتعاون إن شاء الله مثمر ودائم بإذن الله. Radial head fractures are common elbow injuries ranging from simple stable fractures to complex pattern with ligament and forearm involvement. The goal is to clarify when observation is appropriate, when fixation is indicated, and when replacement offers the most reliable path to early motion. For context, we will briefly review the treatment history. In the early 1940s, Kellogg Speed described a radial head prosthesis made of cast vitalium. These prostheses were molded from the native head and placed on the neck after resection. In 1951, Peter Essex Lopresti described the lesion that bears his name, longitudinal instability between the radius and the ulna. He observed wrist pain after radial head fracture or excision, prompting the concept of radial head replacement to prevent instability. In 1954, Mason introduced his three-type classification for radial head fracture. It remains the most referenced classification system. And this classification evolved over the years. In 1962, Johnson added this fourth type, which was associated with an elbow dislocation. Thereafter, some authors advocate radial head replacement to avoid the complication of excision. The first silicone implant were introduced in 1968, but frequent failure, silicone synovitis, osteolysis, and instability lead to their abandonment. Let's move to 2002 with one of David Ring landmark papers, a study that has been cited more than 600 times in the literature. This retrospective ORIF series found 13 of 14 masonry fractures had unsatisfactory outcomes. This study suggests radial head arthroplasty for all comminuted fractures, though its conclusions are limited by the retrospective design and small sample size. But recent clinical series show no worse outcomes with ORIF than with radial head arthroplasty when stable anatomic reconstruction is achieved. Functional results are similar, complication and revision rates are comparable, and a failed ORIF can be reliably converted to arthroplasty. So what should we do when faced with the radial head fracture? What are the current concepts? When evaluating radial head fractures, the priority is to determine whether the injury is isolated or part of combined pattern. Displacement severity and any history of a reduced elbow dislocation are key discriminators. Wrist radiographs are advisable to screen for an Essex Lopresti lesion. Elbow CT is strongly recommended to reveal articular details that radiographs may miss. MRI is not routine, but may be considered selectively for associated soft tissue injury. After this evaluation, several possibilities exist. Radial head fractures with combined injuries like coronoid fracture, ligament disruption, or elbow dislocation require a stability first strategy. Treat the associated fractures and repair ligamentous lesion, then address the radial head. Opt for ORIF when a stable anatomic reconstruction is achievable. As shown here, the patient sustained a complex radial head fracture with proximal ulna and radial shaft fractures. This case was successfully treated with radial head ORIF and 2 dynamic compressed plate. If the radial head is non-reconstructible, radial head arthroplasty is indicated. This case illustrates radial head arthroplasty for a severely comminuted, non-reconstructible fracture to restore radiocapitellar contact and stability, enabling early mobilization and good functional outcome. However, radial head arthroplasty carries significant risks like aseptic loosening, stiffness, pain, instability, infection, or even nerve palsy, so reserve it for judicious indications. For the cases of isolated, non-displaced radial head fractures or minimally displaced less than 2 millimeters without a mechanical block in forearm rotation, treat non-operatively with functional treatment. Outcomes are generally excellent. For an isolated partial radial head fracture with more than 2 millimeters of displacement and no mechanical block, obtain a CT scan to size the fragment and rule out associated injuries. If the elbow is stable, functional non-operative treatment yields good outcomes. Otherwise, perform ORIF with headless screws in the radial head safe zone. A mechanical block to forearm rotation mandate surgery. Perform open reduction and fixation using headless screws. For complete radial head fracture with less than 4 fragments, most can be repaired. Reconstruct the head on table with screws, then secure it to the radial neck with a plate. هنا حتكلم شوية عربي. كما قال زميلي ممكن يعني ناخد the radial head on table with the 4 fragments. If is reconstructible, we fix it with wire and screws, and after you can put a plate. Il n'y a pas de risque d'ostéonécrose. The risk of avascular necrosis is less, and also to guard the most important is to guard the lengthening, la hauteur, لنحافظ على طول radius, all the diaphyse radius, to prevent Essexloprecy syndrome. وزينا كمان احنا في المغرب ما عندناش يعني بروتيزس في البلوك، يعني بنحاول على قدر مجهودنا اننا نعمل اوستيوسينثيسيس. the result is good يعني. Incomplete radial head fractures with cortical discontinuity, stability is the priority. We treat associated lesions first. Management is as follows. If stable anatomic radial head osteosynthesis is achievable, we attempt it, particularly in younger patients, to preserve the native head. When reconstruction is not feasible, we prefer radial head arthroplasty to restore stability. Simple excision is considered only in low-demand elderly patients without associated injuries. This case shows on-table reconstruction restoring congruity and radial length, followed by neck plating to reestablish radiocapitellar alignment and elbow stability. To conclude, management of radial head fractures remains controversial. The aim is a stable, pain-free elbow, and decisions hinge on associated injury as much as fracture morphology. Always assess elbow stability and concomitant lesion. Thank you for your attention. I warmly invite you to our Congress in Morocco. We look forward to see you all there. مرحبا بكم.
Thank you very much, Dr. Abrahim, for elegant presentation. Any questions for radial head fracture to fix?
I have a question about the last few slides. Can you show us again لو سمحت ممكن تفتح البرزنتيشن تاني بتاع الدكتور؟ Can you tell us more about the on table, because we have been debating this. I mean, I have been asked this in my presentation, and probably you seem to have some experience in this. These were your cases or your cases?
Yes.
So can you tell us more about on table reconstruction?
As I say before, we are in Morocco. It's not America or ما عندناش إمكانيات كتير. يعني بنحاول في قدر المستطاع إننا نعمل أوستيوسنتز. ولما بدينا بنستعمل أوستيوسنتز يعني كتير في مراقبة يعني ديال our patient، لقينا بأن عندنا the good outcomes. ودي الليتراتور يعني بالجميع لي بيبرز يعني الغيسون في يعني نفس الريزالت with arthroplasty and with osteosynthesis. يعني واخا تكون la communication is very strong. هنا بنزول يعني التتراديال هيد اون تيبل، يعني بنحطها يعني في التيبل ديالنا، بنعمل reduction as see here. بنعمل reduction with some K1 provisoire. Après on met des vis, des screws, and after we put a plate and we solid all the يعني الراديال هيد مع الديافيز راديوس يعني. وحاجه اللي هي مهمه هي بنحترم لو سيف زون. لو سيف زون يعني ما خاصش يكون ان كونتاكت انتر لا تيت راديال اي لونا لانسيسور اونير في لو برونوسيبيولاسيون.
Thank you very much.
حاولت.
دكتور عبد الرحيم انت اديتنا فيري نايس يعني تريكس، بس انا احب بس ازود هنا ان هو الابروتش هنا فيري امبورتنت. انا بحب اعمل الكابلن ابروتش عشان ما يحصلش كابلن. بحب اعمل الكابلن عشان سيلنت اوسس نيرف. دي نمبر 1. نمبر 2 بسيبريت السكروز الفيكسيشن، بطلعها برضه على الترابيزه انا فيكس بالسكروز. اوكي but this is not the same area on which I put the plate. I should put the plate in the safe zone.
Yes.
Okay, which way pronate the forearm.
Yes.
But very important in to know the circle, how to put the circle. So the width, the largest width of the head of the radius is in this axis. So you pronate and put the head radius in this direction. So this is the largest diameter, and then you create your plate. You do not put the plate and the screws in the same direction. So now you have missed the safe zone. You put the screws on table, then you put the head radius in the largest diameter in pronation, then you put the plate.
Thank you very much. Well, thank you, Dr. Yasser, for the clarification. But I did not think, I've not seen this before. I did not think that you put the plate on the radial head while it's on the outside. I thought you may reconstruct and put it and then put the plate when it's inside. So maybe this is even better, because if you put the plate and you have calculated wrong your axis or something, you get stuck with wrong diameter, or you may get it in the safe zone or some, maybe, yeah. So would you not think you should put the radial head and then put the plate when it's in situ?
Les deux ils sont valables. الاثنين ممكن نعمل يعني زي كده زي في الصورة يعني بنوضع السكرو عند البليت عند نحطها في هذا أو للعكس يعني on fait une ostéosynthèse de la tête radiale. On fait l'ostéosynthèse de la tête radiale sur la table et après soit qu'on va mettre une plaque vissée au niveau de la tête avant, c'est-à-dire en dehors, et après on va la mettre sur le patient, ou bien on met la tête radiale, on la rend à sa place. Comme il a dit Dr Safouri, on oriente dans le safe zone et on met notre plaque. يعني الاثنين ممكن. ما عرفتش حد.
آخر question بقى. Sorry? السيف زون معروفة جدا. أولا لازم الهيد نفسها إنها مدورة كده. بس هي مش سيركل، هي اوفل. عشان هي اوفل عشان لما الريديوس والان يلفوا على بعض تدي سبيس. فانت الهيد دي نفسها هتحطها اوفل في الاكسس ده. اوكي، يعني لو انا عامل كوريشن كده هي اوفل كده ولا كده؟ لا، خليها اوفل كده. خلاص دلوقتي بقت هي في مكانها هنا اوفل. بعد كده احط البليت في السيف زون اللي هو بين الابيكونداي اند tubercular reversal impronation. بس هي كده. Thank you very much. I think we should finish the session, and we thank you very much. And thank you very much.
Thank you.